Thanks, Minister, for furnishing this, the estimates. My first question is in relation to the capital spend. So it's 1.1 billion euros. Could you break that down? Where will that be spent in relation to the overall budget?
I can, Deputy. I'll just get the page now and revert if one of the officials might be able to find that. Do you want to move on to a second question, and I'll come back to this when I have.
Okay. Yeah. The second question is just in relation to obviously there's no shortage of money in relation to the health budget and overall. That's a good thing. It's a good thing. It's not a bad thing by any means. But as we've seen, that you could have all the money in the world you want, is recruiting staff and retaining staff is very, very important. And I know Deputy Crowe has alluded to additional payments, additional premiums that could be allocated to specialist healthcare staff. How kind of serious would you consider that being implemented over the next couple of years in relation to particularly around cost of living and housing? Because obviously if nursing staff or frontline staff can stay in the state, they'll stay in kind of the healthcare setting. So how serious could this be over the next, I suppose, 2 years of your lifetime as Minister?
Thanks, Deputy. I think there's different layers to that. I think the first we discussed earlier on, I think it was with Deputy Crowe, was could we look at localised housing, attached to hospitals, for example. I think that's something that used to exist. I think it makes a lot of sense, particularly for those healthcare professionals who move around quite a lot. I think that could be very useful. In terms of, I know the INMO have made the point around, specific housing supports for clinical staff. My view is really that's a societal challenge rather than just a healthcare challenge. So that exists for nurses and midwives, but for the hospital porter, for the security, for the caterers, for the health and social care professionals, and for people working right across the country in different sectors other than health. So I think there's an all of government approach to that. For example, you've seen the rent subsidies and various other supports in place for renters and supports for people to buy their own home. I think that's broadly how we would do that. In terms of specialist payments, and you may have been only linking it to the cost of living, but you raised the issue of additional payments for specialist workers. I think there is something to that.
Yeah.
I have to be careful what I say because there's nothing agreed with PER and everything like that would have to go through public sector pay agreement. But I do think, for example, where we are really struggling to hire. Broadly, there's never been more people in the HSE. I know we talk about a recruitment crisis, but in fact, we've just had 3 years of record recruitment in a row. So at an all-of-system level, there absolutely is not a recruitment crisis, but there are parts of the system which really struggle. One of the areas, for example, that really struggles is the children's disability services. The clinicians would say to me, the children's services, the complex services are more difficult. They're more difficult places to work in. There is precedent, for example, for an additional payment to emergency department nurses, because the emergency departments are simply harder places for people to work. They take a greater toll. I believe there is an argument to be made for those working in the more difficult areas, where the ones that clinicians themselves say are more difficult, like complex children's services, where additional remuneration could be looked at. But as I say, it would have to be after an awful lot of consultation with PER and as part of a public sector pay agreement.
Minister, there is precedent in that, where our jurisdictions do pay kind of additional payments to specific workers in the health, the healthcare kind of setting. There is precedent on there.
Yeah. And we do it
so
here.
It wouldn't be out of the ordinary.
No. I mean, we pay advanced nurse practitioners more. My understanding, I don't have the figures, but for critical care nursing, for emergency department nursing, there is a recognition that these are some of the most difficult parts of the health service to work in.
Okay. Just getting back to my initial question about the capital expenditure today.
Thanks, Deputy. Yeah, so what I'll get you is a more detailed breakdown, but the capital provision for for construction, for equipping, is 967 million, and then obviously there's more involved to bring it up to the total amount. Some of the big projects involved are as follows: the National Children's Hospital, the National Maternity Hospital, the new elective hospitals, the additional critical care beds, the additional acute or hospital beds, the radiation oncology programme, the primary care programme, which has been a huge success, the enhanced community care projects. To Deputy Shortall's point, replacement and refurbishment of nursing home units, in terms of essentially you end up with less beds because people get more appropriate space, more space, single room occupancy. Mental health projects in terms of expansion of facilities and upgrading. There's a general investment in terms of making things COVID proof. There's been a very significant investment in the budget we have here for the National Ambulance Service, for the fleet and for the bases, climate action projects, and then equipment replacement programs as well.
Right. Okay. Right, that's good. Just in relation to the 970 extra beds that have been included in the public health system, that's a good thing. Very, very good thing. And that excludes critical care. So how many critical care beds have been included since 2000? Or since the start of the decade, so it's 3 years.
Thanks, Debbie. So I can give you from the start of 2020, so just pre-COVID, we've got an extra 65. Right. So we've gone up from 258 beds to 323. That's a 25% increase. And then this year we're putting in another 29, which will give us a total increase of 94 beds, or 36%.
Okay. And obviously, over the next course of the next couple of years, that will incrementally increase as well. I presume that's the...
That's right, yeah. So we're moving now from phase 1 to phase 2. Phase 1 essentially was putting extra critical care capacity in a lot of different places as quickly as possible. Phase 2 is more strategic. Phase 2 is in line with a national strategy where we're creating centres of excellence, or critical mass hubs, critical care hubs, and we're building them out.
Okay. Just another question around women's health issues, and I know there's been a lot of really good work on this, and that's a very, very, very good thing. But one kind of criticism has been, and again, the funding is welcome around endometriosis. It's a very prevalent condition around women. But one of the criticisms from those that are kind of living with endometriosis and the care is around diagnosis. Obviously, some women will find it years before they can get a diagnosis. Some women have to go abroad for treatment and so forth. But one of the criticisms was the kind of knowledge of GPs around endometriosis and the condition, and via the primary care system. Because there was an AV presentation there a number of weeks ago from women that have endometriosis, and it was kind of hard to hear women having to go through years and years without being diagnosed. And I think that was one of their criticisms around GP knowledge of this condition.
Thanks, Deputy. So I fully agree. And what we're providing now, and indeed there's funding in the budget here before us as well, to expand the service. Essentially, up until now, there has been very limited clinical access for women. As you quite rightly say, there has been limited knowledge in general practice. The GPs haven't had the kind of specialist support that they need. And there has been very limited specialist services then available for referral from the GP. So even if the GP did know what was going on, there weren't many options for them in terms of referring their patients. That is now fundamentally changing. We're funding the ICGP to produce a quick reference guide for GPs and to do training, much like they've done on menopause. You'll be aware there's a really successful quick reference guide for GPs was launched last year. There's specialist training now for GPs. The ICGP have really taken this on board. We funded a women's healthcare post, a fantastic doctor, Dr. McCarthy, and they're working with the ICGP on GP training, GP supports, And then, as you're aware, we now have referral pathways for the GPs into centres around the country for secondary care. And we've now set up the highly specialist units as well. In fact, I was with the one in Tala recently, and it was just amazing to see this new team of experts, multidisciplinary approach. And what they're saying, Deputy, is that the impact this is having on women's lives is enormous. They've been doing fantastic work, and it's a service. We're rolling it out, but it really is going from strength to strength.
Minister, over time?
It can.
Yeah.
To be honest, we've put in place a lot of infrastructure now for these 3 layers. So the intention would be, and certainly the view from the clinicians would be, once we have the supports in place of the GPs, fully staffed up teams for the secondary care, and then the fully staffed up teams for the really specialist care. Let's see. We've also got to remember the 21 see and treat gynaecology clinics. So there's a whole new network of support and expertise in place. It's having a big impact already. I can assure you, Deputy, if what we find in a year or two is that more specialist resources required, we'll put it in place.